Good morning, everyone. We'll give it a few moments as folks trickle in, and then we shall get started. All right. Oh, looks like we've got some more trickle in. Give it a couple more moments. Okay. I think we can go ahead and get started. Hello, everyone. Welcome, and thank you for joining today's SRS Foundation State of the Science. The SRS Foundation is pleased to host today's educational webinar on the topic Orexin, the master integrator, looking beyond sleep-wake control. Next slide, please. So I would like to give a special thank you to our corporate partners for supporting this program. These include Alkermes, Eisai, Takeda, Harmony Biosciences, Jazz Pharmaceutical, and Centessa Pharmaceuticals. So without further ado, I'd like to introduce and turn the webinar over to Dr. Anne-Marie Morse.
Thanks so much, Phil. So if this is your first time attending an SRS State of the Science, I'm sorry that you've missed incredible education in the past, but also excited to be able to share today with you because we have a star-studded list of panelists who I'm really excited to dig into the concept of orexin and be able to really look beyond what we know about it in regards to sleep-wake control. I'm Anne-Marie Morse. I am a neurologist with special training in child neurology and sleep medicine specialist at Geisinger Medical Center. Craig, can you provide an introduction?
Sure. So I'm Craig Chepke. I'm a psychiatrist in private practice at Excel Psychiatric Associates in the Charlotte, North Carolina area, Huntersville technically, adjunct associate professor of psychiatry, Atrium Health, and actually now the chief medical officer of Psych Congress.
And congratulations, I saw that just recently.
Thank you.
And if you haven't been to a Psych Congress, I strongly encourage it. The SRS has formed a partnership with them in order for us to bridge that gap and be able to reach more providers outside of just sleep medicine alone. Gert, can you please provide a introduction? You're muted.
Oh, I hope it's the last time I make the mistake. I'm also a neurologist by training with special interest in sleep medicine, and particularly those people who are not able to stay awake during the day. So that's already close to narcolepsy, both from the clinical perspective and the research perspective. And what I see is that it's not written. I'm from the Netherlands, so from Europe, and I'm one of the co-founders of the European Narcolepsy Network already almost 20 years ago.
Wow, that's amazing. And I'm super excited to have him here today. What he didn't share was that we were at an advisory board together and I was extremely fangirling in regards to, I'm like, I love all your work. I read your papers on endocannabinoids and narcolepsy or orexin system, as well as gender differences. And so really excited to hear some of his thoughts today. And last, but definitely not least, my bestie from the West Coast, Atul Malhotra. Atul, if you can please give an introduction.
Sure, I'm the vice chair of medicine here for research. I'm actually a pulmonologist. I don't know a lot about neurology, so I'm here to learn and unencumbered by knowledge. Hopefully, I'll learn from all of you guys. I do a lot of work related to sleep apnea and some related to other sleep disorders, including narcolepsy, but I'm not an expert, so I'm here to learn.
Yeah. And although Atul likes to undersell himself, one of the things that he also didn't share is that he's an incredible researcher in the area of critical care. And so we will be digging into some of that as well in regards to orexin's role in terms of the inflammatory system, things like sepsis, as well as just critical care management, but definitely having a focus on obstructive sleep apnea. So we're really here to talk about orexin and recognize that an exploration of orexin science with a focus on the complex physiologic roles of orexin across the body learned experiences from orexin antagonism in anticipation for orexin agonists. This really is setting the stage for what is it that we're going to cover today. In regards to our learning objectives, we're going to discover the critical role of the orexin system as it plays not only in the sleep, wake, and circadian science, but also in other fields and areas such as mental health, feeding and metabolism, plus many more. We're going to investigate the potential impact of gender differences, the relationship to sex hormones, as well as potentially the endocannabinoid system, as well as other signaling systems, and even potentially exogenous cannabinoids. And then finally, our goal is really for you to take away potential research opportunities and clinical pearls for your practice today. So it would be amiss if I didn't start off the conversation around narcolepsy, because really this is something that has proven to be a very significant reason as to why we're seeing the dawn of the selective orexin agonist coming to light. And so what we see is that when we take a brief historical review of narcolepsy, we see that there was the first discovery or appreciation of a genetic influence in 1973, where there was the first report of a dog with narcolepsy. And so it was viewed that this must be an autosomal recessive gene. However, it wasn't until much later that there were the identification of hypocretin and orexins in the receptors in 1998. And then in 99, we see that there were hypocretin mutations that were causing narcolepsy in mice and in dogs. Now, one of the things I think is important is that when we currently think about the diagnosis of narcolepsy, especially narcolepsy type 1, we very frequently are accounting for it as something causative by a selective reduction or absence of orexin A. However, what you're seeing here is that the historical context of how we discovered this relationship was not just due to the neuropeptide alone, but also in combination of different variable changes in regards to the receptors, which we are going to go into as well today. Now, an additional area which we won't cover in detail today, but one that I think is an interesting suggestion that has emerged in 2021 was the suggestion of possibly, is this actually not an inflammatory etiology that causes a destruction of these neurons, but is it or is it rather an epigenetic silencing of the expression of orexin, which really is an interesting concept to think about. However, we're still waiting for additional research to continue to help us better understand this concept. And we're going to be able to talk a little bit more just about orexin and its signaling pathways today. So when we're talking about orexin, it's important to know that these are two neuropeptides that are coming from a singular pre-proorexin, and this is going to result in your orexin A and orexin B, also known as hypocretin 1 or 2. In 1998, you had two different groups identified around the same time, one calling it orexin and one calling it hypocretin. Orexin has become the more popularized term, especially when talking around the CSF testing that's available in the United States, as well as the medications that we're seeing, both for the antagonist as well as the agonist. And what you're seeing is that you have these two peptides, neuropeptides. One is orexin A, which is a 33 amino acid long peptide, and orexin B, which is 28 amino acids long and has some similarity to orexin A. Now, with these signaling peptides, it is important to know that there are two specific G-coupled protein receptors that they can act on. And like any G-coupled protein receptor, they generally are going to signal a very complex cascade of signaling that therefore can have a very wide range of outputs related to it beyond just wake promotion. Now, one of the things that is important is when we're talking about orexin A, we do see it has strong affinities to both orexin 2 and orexin 1, and perhaps a stronger affinity to orexin 2 than orexin B. But what is a common place between both of these is when they are signaled, it is required that this non-selective calcium channel is going to allow for the signal transduction to occur. And so this elevation of intracellular calcium is a hallmark of orexin action. The reason I give this very important kind of implication is because of the fact that we now are introducing even further degrees of where pathology potentially can occur in regards to the signaling cascade. If I'm not appropriately signaling through a calcium channel, I may then see dysfunction despite having appropriate orexin A and orexin B, as well as appropriate receptors. And so as we're looking at this, the question becomes, what is the consequence or what is the impact of the downstream signaling? Well, in 2023, this paper came out, which really gives an overarching consideration around the network of orexin receptor signaling systems. And so this is a molecular network map. And no, this is not intended for you to actually be able to read. And so if you're going, like, there's something wrong with my screen, everything looks very blurry. It's not your screen. It is just that this is such an overwhelming depiction of all the downstream signaling effects that it is going to look relatively blurry. In fact, I think it's probably still a bit blurry in my head, even though I read this paper multiple times. However, I'll give you a quick summary of what you're seeing here. And what you're seeing is that down here in all these little red areas, it's giving you all the different downstream effects, which include things like steroidogenesis, having autonomic stability, inflammatory response systems, and so many more. You really are seeing in that map the impact of the rexinergic system, where you see that it can impact everything from our autonomic system, our regulation. You see very significant relationships to calcium regulation, not a surprise there, as well as going through all these other areas, including psychological stressors and mental health responses. And so what is important as a distinction here is that many times we're thinking about this as a unidirectional response. It is in fact not unidirectional. It very much is bidirectional. You give a little, you get a little. You give a lot, you get a lot. And sometimes you end up with an imbalance of that give get. And so when you're thinking about the orexin system is really not just a binary, I'm on or off, or I'm causing just a singular, I'm awake or not. It really is an integration center where we're seeing that it has roles not only in wakefulness, but across emotional processing and stress, metabolism and feeding, which is very apropos for its name in nomenclature, thermogenesis, immune status, cardiovascular status, respiration, sexual arousal, motivation, reward, neurocognitive processes, and nociception. And so with that, this was intended to kind of set the stage for us to dig into the discussion I'm going to have with my esteemed colleagues. So when we're looking at everything that we just covered, we saw that there's significant implications in terms of steroidogenesis, and there also can be some interaction between things like the estradiols and even the potential expression of orexin receptors in the brain. Now, there's been a lot of debate, specifically in narcolepsy, as to whether or not there are, in fact, gender differences. We see that you have some studies are giving suggestion, yes, there's very strong differences. The most recent one that I know Lucy and Eve were a part of gave a suggestion that perhaps there are not the gender differences that have been previously accounted for in animal models and in humans. But even within their paper of giving a suggestion of not having gender differences, there are clear gender differences that occurred over age. So the younger children having a different phenotype, male versus female. And I think that becomes important. I would like to just pose the question to the panel. What have you experienced in regards to orexin and gender differences, or what data have you read or been a part of generating that would give the suggestion that there either is or is not significant implications in regards to orexin and gender?
Well, I could say something. Thank you for the introduction, Anne-Marie. I have to say, I think we are starting to learn a bit about these gender differences. And I think what makes it quite complicated is that narcolepsy may occur on almost any age. And that makes it very difficult to be really sure whether there is hormonal influence. And also when you start treatment, that also will impact let's say, what we can identify regarding these differences. I think what motivates us, we recently performed a questionnaire study, and one of the motivations was that there has been a mice study performed in France by Christelle Peyron, in which she found that the number or the frequency of cataleptic attacks was, let's say, very much regulated by the phase of the cycle in the female mice. So we were much interested if you could, let's say, find this or identify this in human narcolepsy as well. But well, the result of the questionnaire study is that we do identify some differences, but mainly in sleep phenomena and like the level of disturbance of nocturnal sleep and the level of excessive daytime sleepiness during the day. There are impacts of the cycle. Mainly premenstrual part, there are more complaints of excessive daytime sleepiness and more complaints of nocturnal sleep, but we could not identify that there is a real impact on the occurrence of cataplexy. But yeah, what makes it a bit difficult that the majority of patients, they were treated. And of course, we didn't, let's say, compare these data to, let's say, male data, but we just ask in the group of female narcoleptic people to inform us about it. But so at least there seemed to be impact of the cycle. But it's not that easy to really know whether it's really much different from expressions in males.
Interesting. Atul.
Yeah, I could add one or two things. I think I used to believe there was a male predominance in narcolepsy, but I think there's a lot of misdiagnosed sleep apnea out there. So my take on the literature and my clinical experience suggests that they're more similar and different across genders, male and female being equal. And I think Yves Deloria had a paper in Sleep a few months ago that suggested they're kind of more similar than different in terms of characteristics of their type 1 narcolepsy as well.
Yeah, well, one of the things that I actually would wonder, based on what you just stated, Gert, is it that there is an absolute difference versus may there be a catamenial difference, right? And in reflecting on neurologic experience, we see catamenial differences very commonly. We see it in migraine, we see in epilepsy. So why wouldn't I see it in something like narcolepsy or even idiopathic hypersomnia for that matter? We know that a part of normal premenstrual symptomatology is that you may see excessive daytime sleepiness or fatigue. You can see mood instability. There is even, and Craig, this is where you can correct me if I'm wrong, PMDD. Is that a correct diagnosis? And
It
can you
is.
expand on that acronym a bit, just because I think it's like premenstrual something dysphoria.
Yeah, premenstrual dysphoric disorder. So that the symptoms occur solely or based off what the phase of the menstrual cycle the individual is in. Now, what's interesting about that is that with SSRI, so compare and contrast that to depression, major depressive disorder. So that is something where we know that SSRI medications take 4 to 6 weeks to take effect. But for PMDD, it's dosed for just a week or two at a time. So there are some definite differences there, and we see differences also in bipolar disorder as well. That there is in bipolar disorder there is a greater exacerbation of symptomatology around hormonal changes. So during the menstrual cycle and at menopause, which that brings up for me that one thing I didn't disclaim in my introduction is that I'm not a sleep specialist. I did not do a fellowship, not boarded in sleep medicine. More of a DIY education. So I'm also here to learn, like Atul said, because I have less experience in the field. I'm a person living with obstructive sleep apnea, and that's what kicked off my passion to study sleep medicine. That was probably 13, 14 years ago. But one thing that I was thinking of in terms of the equivocal nature of the literature is that as mentioned, there's menopause and then there's menstrual cycle. So when are these studies being done looking at the changes between the differences between men and women? It could be different depending on what age it is and things of that nature. So I expect that this information is going to be evolving over time as more research is done.
Yeah, and you also enter into the question as to whether or not are these men and women or women who are on hormonal therapy, are women who have PCOS, are these women who have had a surgical kind of menopause where they've all of a sudden had everything removed and there's a very abrupt presentation of these symptoms. And so it raises the question, is it enough to just evaluate them as narcolepsy male female versus narcolepsy male female? We're going to look at your testosterone, we're going to look at your estrogen, we're going to look at your estradiol, because I do think that these things are functions that matter. And I would just share anecdotally that in speaking with many patients from all over, women do tend to describe an intensification of their symptoms. Similarly, they describe sometimes an improvement of their symptoms with things like pregnancy, which really does again raise the question as to why would that be. And so I do think that this is an area that continues to require some discovery. However, I also think this is an area when we're thinking about the phase 2 and 3 studies that are occurring with orexin agonists, as to perhaps these are some questions you may want to add in to understand, is the person experiencing an absolute benefit consistently versus is there some variation? And the reason I think that can be a very impactful thing is that people living with these conditions many times feel vulnerable to a lack of predictability of everything, including response to treatment. And so for women who may either see this, I'm normally on X dose, but it's too much at this time of a month or just not enough, it can sometimes lead to a discontinuation of a medication that may not necessarily be the most optimal. I don't know if anyone has any additional responses to that as a research question, or how we may be able to better understand that as a research question. And I think the earlier statement of it also depends on the age of the individuals really is important, because we do see that there can be things like precocious puberty that occur. So there's clearly a hormonal relationship. And again, we've already discussed about the steroidogenesis, but what may there be from the other end of things?
Yeah, I think it's speculation, but I fully agree. I think we need to pay much more attention to this, and particularly prospectively in these studies that are currently performed.
Yeah.
And maybe the other point that is indeed very intriguing that you just mentioned about pregnancy. It's really some particular people with narcolepsy with cataplexy just tell you have hardly any cataplexy, even despite tapering off of their previous medication. That's very intriguing. And there the question also, is it hormonal, or might there maybe be, if there still is an immunological part as part of the explanation, and I think it's unsolved, but that needs much more attention, because it's intriguing how to explain it.
Yeah, no, I really think that this is a very important question that I think when these medications come to market, some real world evidence would be very helpful. And then again, the other end of the spectrum is orexin antagonists. What can we learn from that? Is there a gender difference in regards to the responder profile? Is there catamenial differences? Are there other factors that may make a difference in regards to what that response is? So I think kind of in a similar vein, this is talking about how the endogenous hormones. Atul, did you have something else you wanted to add?
We had a paper recently on daridorexant, one of the orexin antagonists
Yep.
in mild sleep apnea, and it was interesting. It actually helped quite a bit with sleep parameters and sleep quality and that kind of thing, and kind of made an argument to study in the context of either COMASA, sleep apnea with comorbid insomnia, or potentially for CPAP adherence, where some people get treatment emergent insomnia with that. And I think orexin antagonists in that context haven't been talked about as much, but the recent paper I think was interesting.
Yeah. In that paper, did you have any and this may not have been a part of your analyses, but do you recall observing any significant differences between males and females?
I don't think we looked at that. I don't remember that result, but I think it was a relatively small sample, so we didn't do a lot of subgroups.
Got it. Yeah. So maybe that's your next study that you can do. That's what we're about. We're about generating ideas for future research. Now, in a similar vein, thinking about how our endogenous hormones may influence the orexin expression or impact, what about other complementary systems? I would say one that has been very interesting to me is potentially the relationship with the endocannabinoid system. I would also say that I've been fascinated about orexin and its relationship with something like CGRP. There's very limited data on this, but it does give the suggestion that there is a bidirectional relationship there, where orexin inhibits the prejunctional release of CGRP, and CGRP modifies. The reason I bring that up is that people living with narcolepsy are much more likely to experience headache syndromes, and we know that the CGRP medications at this point are some of the leading in regards to migraine management and headache management. The endocannabinoid system has been something that has struck me in regards to the research, giving a suggestion that there may actually be bidirectional agonism and antagonism between the endocannabinoid system and the orexin system. Gert, I think you've done some work with cannabinoids and looking at the utilization of cannabinoids, and even maybe perhaps something with the endocannabinoid system. Do you have any thoughts around this?
Yeah, indeed. We started this last year, and maybe it's relevant to know that let's say in the Netherlands, cannabis is free available. So what we did do, we studied the use of cannabis in a patient group versus our natural population, because there are quite reliable data regarding the use in the population. And what we find is that there was an overuse of cannabis in the people with narcolepsy, and we asked them in this questionnaire for reasons, for indications. Was it just, let's say, for pain or general for well-being, or was it really related to symptoms of narcolepsy? And then it turned out that the majority explained that it was not just, let's say, for pleasure or well-being, but they had the impression that they, particularly for nocturnal sleep, they slept better, and they may have less complaints of hypnagogic hallucinations and other disturbances in sleep. And of course, this is open studies, but I think it's good indication that we need to learn more about this aspect as well.
Yeah, I think that this is an area for me that I'm absolutely fascinated on, because I grew up in the training period where cannabinoid products were being utilized for starting to be studied for use in epilepsy, and so we now do have a cannabinoid product that is available for treatment in epilepsy. But I remember there being still such stigma around it, of that it's purely used for enjoyment and pleasure. It doesn't, and I really was fully unaware of the fact of how significant the endocannabinoid system, and even have been humbled by recent clinical trials in Fragile X syndrome, for instance, around topical cannabinoid CBD THC containing products, because there's an innate abnormality in their endocannabinoid system. This is going to tie in also into some of the mental health pieces. I would love to know from Craig, when you're thinking about the experience of those who maybe are utilizers of cannabis containing products, is there and this isn't to stigmatize, it is really to say, is there a particular profile that kind of comes to mind? And is there an outlier in that profile that perhaps may also give some thoughts around someone who may actually look like a person living with narcolepsy or hypersomnolence disorder? Because I would say, similar to what Gert just described, of that, it is not uncommon for my patients to say, I utilize this for the symptoms of narcolepsy, not just for pleasure or anxiety or depression or an escape. It actually modifies my symptoms. So would love to kind of get some thoughts from you about that.
Well, I would say in terms of, is there a profile of someone who uses cannabinoid products? I would say not anymore. From what I see, I see all across the socioeconomic spectrum, racial spectrums, whatever spectrum you can imagine, that it's really now homogenous. That there is it's homogenous or unpredictable. You couldn't say, oh, this is what someone who uses this type of cannabinoid, and that applies to either whether you spread it towards using marijuana or using a CBD product. It's really all over the map, and so I think that's something that we need to, on a clinical basis, really ask in a non-judgmental way, being very important. Because it's very easy to put stigma into that discussion, and I think we got to take that out of it if we want to know. And the quick way I often approach that is say, look, I could care less from a moral perspective, legal, it's none of my business, but medically, as your physician, I need to know what's going into your body so I can see how it's affecting you, how other medications can interact with it, so on and so forth. So in that regard, then I don't think there's a profile anymore. So if we've had a stereotype, we need to throw it out, because everyone has the potential to be utilizing a cannabinoid product. In terms of symptomatology, we definitely see that in mental health conditions, that, oh, I use it to treat my, and you insert the diagnosis here. And I trying to recall specifically cases in patients that I've seen with narcolepsy, if that's been the case, if they said that. And I can't recall one off the top of my head, but one thing I think we should keep in mind is that we've discussed the underdiagnosis of narcolepsy, and if we look at someone who's utilizing a cannabis product, and we say, oh well, of course they have low motivation and they are laying around sleeping all the time, they're high all the time. Well, maybe it's not that. Maybe they do have a hypersomnolence disorder, and that there is a self-perceived role of the cannabis product in self-treatment of those symptoms, which may not be diagnosed or diagnosed correctly.
Yeah, and I would say that the added concern there is cannabinoid products are one of the things that can cause a quote unquote false positive MSLT. And
Mm.
it raises the question of is it so false positive? Is it that you have a selective bias of the person who ends up getting the MSLT, who is also utilizing cannabis, may actually be a specific
Mm.
subtype of a person living with a hypersomnolence disorder? Atul.
Yeah, we had a paper a couple of years ago from the geriatric clinic. So older folks. We did a survey about 600 people, as I recall. About 30% self-reported cannabis use. This is in California, where maybe it's more prevalent, and a lot of them, to Craig's point, were sort of self-medicating for sleep disorders and that kind of thing. So 30% is a lot bigger number than I would have anticipated. And
Yeah, and I would say that the part that I think is requiring ongoing exploration is as has been described, that individuals living with narcolepsy may describe a more sustained benefit from self-medicating, where when you look at the literature around cannabis use in sleep, it really depends on what you're utilizing, whether or not you're using CBN, CBD, THC, et cetera. But an overarching theme, mainly with CBD, THC containing products, has been in the acute, I see benefit. Chronic use, I start to see the fragmentation and the breakdown of that previously acquired benefit. And then with stopping, I may have a rebound insomnia. Again, this is an area that really requires a lot more of research, but also one for me that when I'm thinking about the orexin agonist coming to market, I want to think about what is that profile going to look like? What is the real world evidence of when someone is using an cannabinoid and then they have an orexin agonist? If there truly is some synergies in how they can agonize and antagonize one another, do we find that that modifies the dose that's needed? Do we find it modifies the side effect profile? And this brings me into what we've learned about the orexin antagonist. So one of the next questions around the role of orexin in mental health and substance use disorder. This is an area that I think is fascinating because we generally are only thinking about orexins, again, as putting me asleep, keeping me awake, if I'm antagonizing versus agonizing. We know that there is a selective orexin agonist that just had incredible results with phase 3 data, that its primary endpoint was insomnia. I'm sorry, its primary endpoint was depression, with looking at the insomnia also benefiting and demonstrating that. On the flip side, there also is evidence of a dual orexin receptor antagonist modifying the substance use disorder experience. And so some of this is I think, very interesting, because if you take something like opiate use disorder in animal models, there's been the suggestion of that there's an upregulation of the number of orexin neurons. They're smaller in size, but greater in number. And recognizing that some of the concern about agonizing the orexin 1 pathway has been regarding addiction, because that's my more hedonic pathway. So Craig, I don't know if you want to take the first kind of hit at this. Your thoughts around orexin, mental health, substance use disorder, whether you're looking at it from the antagonist end or what you might be thinking about as we may see orexin agonists start emerging.
Well, I'm looking at it from every end, Anne-Marie. So this is one thing that really just enchanted me about orexin and its neurobiology when I first learned about it years ago, was that it's just so very elegant, but also is so intertwined with so many things that I've been spending my entire career researching in mental health. Is that, for instance, all the sleep-wake centers that the orexin neurons will project to a lot of monoamine the cell bodies where we have so much of psychiatry tied into. But then also orexin can also interface with the HPA axis as well. And in terms of antagonists, then we have, you mentioned seltorexin is the name of the medication that's investigational currently, and it's being looked at for major depressive disorder with insomnia symptoms. So the entire history of psychiatry, we've looked at just major depressive disorder, take all comers. But there are 227 different ways that one can get a diagnosis of major depressive disorder in terms of the combination of the symptoms. So someone could have hypersomnia or insomnia. They could have hyperphagia or hypophagia, anorexia. So it's very challenging, and we're starting to look at these subtypes in an attempt to have a precision medicine-based approach. So seltorexant is very interesting. They've had some great data in the phase 3 clinical trials, and hopefully should be submitted to the FDA soon. But in terms of the way it's being looked at in terms of the HPA axis, they have data showing that it actually can reduce cortisol levels, which the HPA axis has been studied for a potential etiology for major depressive disorder without any specific therapeutics making it through. But again, it's such a heterogeneous population, and taking all comers for MDD, it's difficult to do. There's data for orexin antagonists in, as you said, with the reduction of substance use disorders potentially. And going to the flip side, the bulk of the information and studies for the orexin 2 selective agonists have been looking at the hypersomnolence, but orexin also plays a role in things like vigilance and attention, and as you mentioned, motivation. Things that are very interesting to anyone considering mental health. So things like ADHD or cognitive deficits across transdiagnostically across a number of different diagnoses. And so maybe there could be a role in the opposite, major depressive disorder with the more neurovegetative symptoms for ADHD. So many different aspects. I mean, my mind starts racing once we start talking about these. I think that there's a lot of potential when we start looking at what orexin antagonists and agonists can do. When we get more selective about them, there's Orexin 1 actually has been looked at, Orexin 1 antagonists selectively have been looked at for anxiety disorders as well, without any therapeutics making it through. So there's, I think, really a lot of untapped potential that we're just starting to break the ice of.
Yeah, no, I agree with you. Atul and then Gert.
Yeah, so as you know, Anne-Marie, I have some interest in GLP-1 receptor agonists as well, with tirzepatide. Full disclosure, I consult for Eli Lilly, but there's some data that those medications can affect addictive behaviors. So hedonic eating for pleasure rather than for hunger, alcohol use disorder, tobacco, even gambling, those kinds of things get better with GLP-1 receptor agonists. There's some data that affects the orexinergic systems to the lateral hypothalamus. Whether it's a direct effect on the dopamine reward pathways or whether it's orexin mediated, I don't know, but it is sort of an interesting tie into this. The other point I'd like to make, which is unrelated, is that David Holtzman, that group at WashU and St. Louis, has some data in Alzheimer's with lumborexin and these things. And I don't see that on our list here of things to talk about, but I have some grants in the context of sleep apnea and Alzheimer's. I've gotten interested in that space, but it's really quite compelling, the orexin antagonists in terms of amyloid and tau and these kinds of things in rodents, and some human data as well.
Yeah. And the question is whether or not, is it the antagonist or the agonist for the neurodegenerative disorders? Because I think that what you're seeing with those conditions is an imbalance. And so I continue to say the world that we're seeing is kind of similar to the endocrine world, where I can live with diabetes. And if I have type 1 diabetes, I don't make the insulin anymore. If I have type 2 diabetes, I first see an over-exaggeration of the insulin because I become resistant to it. And so I think we're going to start discovering that across the hypersomnolence disorders, the neurodegenerative disorders, and beyond. And I agree with you. With the world of GLP-1, there is data to give the suggestion that there's both direct and indirect interaction with the orexin system, and that likely is playing a significant role. And again, playing homage to its name in nomenclature, right? Gert, please share.
Yeah, maybe by now it's a bit off topic, but I wanted to mention that we are talking about all the basic functions in which orexin is involved, but I think it's also making sense when you consider that from the anatomical point of view, this is what you expect, because it's a very small number of cells in the central part of the brain, in the hypothalamus, with connections to all parts of the brain and the spinal cortex, the cerebellum, so that's a configuration of some directing function. Another thing that is thought-provoking that you see from the evolutionary perspective, you see that the hypercutaneous system starts to evolve when we animals and like us humans develop central nervous systems. So it seems that when brains become more complex, you need an integrator. And it might be that our Orexin system is this integrator, and that explains why so many basic functions are involved, and mainly also functions that say are very important for survival.
Yes. Yes, and I think that that also gives a very good explanation, or at least some direction for us to think about when we're talking about the multimorbidity that many people living with narcolepsy may experience, but also in the same capacity that Atul had just mentioned around neurodegenerative and otherwise, is that where we're living in a world where more people are trying to get away with less sleep and very erratic, irregular sleep, that also is going to cause orexin dysfunction because it's trying to compensate, and it can only compensate so much, and then we see these other downstream effects. And so it does raise a lot of question. I think the other part that for me, and this might be even jumping to some of the future research piece, is that at this point, I think in sleep medicine, we play a lot of kind of confidence in the CSF orexin testing, which again is only testing for orexin A and has its own limitations. We have no idea about orexin B and getting those types of measures. We also have no clear data that is showing us this is what the balance of orexin versus. So can you have a relative deficiency compared to what everything else is? But also, what about your peripheral orexin system? And there's a lot of discrepancy in the field in sleep medicine of how confident they feel in regards to other fields and other disciplines that have published on peripheral orexin testing and whether or not that is a confident measure. I think that if it is even a confident measure, I think one of the hazards is thinking that it will be reflective of the CSF measures, because we know that there many times can be divergence there. This I think is where we can also start now focusing a little bit on orexin more broadly in sleep, and thinking about it in regards to potentially sleep disorder breathing or even other sleep disorders. We've talked a little bit about insomnia already, but I also think that there's going to be a role for potentially things like REM behavior disorder. And so Atul, I'm going to kick this off to you first, being that you're our pulmonologist on the call. Is what are your thoughts around orexin, its role in sleep disorder breathing? You had just stated that you had looked at it from an antagonism perspective. Do you think that there's roles for an agonism? And may they actually, even though it's the same neuropeptide, may they have different impacts on why the breathing improves?
Yeah, I guess the short answer is I don't know. I'm told that there are monosynaptic projections from the lateral hypothalamus to the hypoglossal motor nucleus, which controls the upper airway muscles. And so, at least in theory, orexin agonists could help with upper airway tone. That's a speculation on my part, but certainly possible. I was at the World Sleep meeting in Singapore just now, and there was a group out of Australia. I don't know who they were. I didn't recognize them, but they were giving orexin agonists to OSA patients with residual sleepiness. And it was interesting. The MWT I think of as a fairly noisy test, but they all pegged at 40 minutes in terms of they got the drug, and all of them got very impressive improvements in their maintenance of wakefulness test. So we had a consensus thing, a Delphi conference last year or two. Jorg Stier was the co-chair with me on that, looking at OSA patients on CPAP, and about 10 to 20% of well-treated OSA patients will have some residual sleepiness, and whether orexin is a culprit there, or whether it's a therapeutic target there, I don't know, but certainly the data out of Australia was quite compelling.
Yeah, yeah, and I think that that becomes just an important point in general is for those patients who have adherence and it looks as though that their OSA is being treated appropriately and there's persistent sleepiness. One, I think the first call to action is making sure we're reevaluating and not missing another sleep disorder, whether it's that they have restless leg, periodic limb movement, but also a hypersomnolence disorder. When you're looking at the retrospective claims data, it gives a suggestion that individuals with narcolepsy may be as high as 18 times more likely to have obstructive sleep apnea. And so there is existing therapies like sulfonylurea solriamfetol or your modafinil that can be utilized to improve wake promotion in individuals who have obstructive sleep apnea and sleepiness. But I do agree that if there's a dual bang for your buck where it's going to improve my wakefulness and potentially affect my breathing and maybe even affect cognition, that may actually be something that would be in favor. Gert, do you have anything that your thoughts are in regards to orexin's role in whether it's sleep disordered breathing or other sleep disorders, RBD, insomnia, nightmare disorder, anything else that you think may be relevant?
Yeah, but I'm afraid it's still a bit speculation, but I think it's making sense because we know about what just was explained by Atul about the connection between the hypocretin system and the respiratory system. Regarding RBD, I think it's intriguing because, of course, RBD is part of the phenotype of narcolepsy. So you might expect there's an impact. On the other hand, let's say, as far as you know, the anatomical regions that are involved in the development of REM sleep behavior disorders seem not to let's say, use transmitters that not, let's say, orexin mediated transmission. So maybe if you try to use it for these kind of orders, you're shooting like with a big gun on a bug. But I think from the theoretical perspective, it could make sense. I agree.
Yeah, no, I really think that that's important. One of the other things, just to circle back on the substance use disorder, and Craig, you can probably correct me if I misstate this, but individuals who, let's say, have opiate use disorder, for instance, their likelihood of relapse greatly increases if there is a sleep-wake circadian disorder accompanying it. So individuals who, let's say, are experiencing something like insomnia. And so when thinking about things like the dual orexin receptor antagonists, there's the question of, am I just modifying the risk for relapse because of the fact that I am reducing that insomnia experience? Versus am I actually modifying the cravings or the hedonic behavior because I'm antagonizing the potentially orexin 1 pathway, which would make me more likely to crave the opiate. Craig, any thoughts on that?
I think it's a complex question because I think both are likely, in my opinion. The neurobiology you mentioned there just a little bit, but also just thinking it psychologically. When someone has insomnia, there is we know a well-established link between that and suicidality, and I just think of that as a person of you're up there, you're up in the middle of the night, no one else, very few people are up, and the all of life's worries, you feel isolated already and you think, I can't take this anymore. So someone could reach for something that could be an attempt to end their own life, or they could reach for a substance of abuse that they think might help them to feel better in some way, shape, or form. Also, potentially the other people who are up in the middle of the night could be your dealer, or a dealer at least. There's a lot of different pathways where I think that there could be potential benefit. And I don't know how it would be very difficult to disentangle that in a real world perspective of figuring out what is the kind of factor analysis of how much of it is due to each one. That'd be very challenging, but I think all roads converge on. I think that there is a great potential for benefit at the very least.
Yeah, one of my colleagues in Vancouver is a psychiatrist who does also pain management. And one of his areas of research is in regards to opiate use disorder. And they were describing to me a protocol that they use in the office that I was like, you do this in the office? I was like, my mind was blown. But they actually use a fentanyl infusion to get to the level of where the person's kind of addiction level is. So not everyone has the same amount that they need to be able to experience that high. And the reason I bring this up in regards to an orexin story is because let's say I have the person who is in a recovery journey and I do try using Adora and I'm using whatever the maximum dose is and they're not experiencing benefit. Does it mean that that drug is not beneficial, or does it mean that their biology is innately different? If the suggestion seen in animal data where there is an upregulation in number of orexin neurons is different. And so I think that this also starts to bring about a different call to action of like, can you individualize care in a better way by looking at these interactions and understanding that the biological needs may be different? It's not just the pharmacodynamics or pharmacokinetics of the medication. It is also understanding the individual differences in what may drive a greater need of antagonism in one way or another, as well as even maybe potentially the tinkering of how much Orexin 1 versus Orexin 2 do I need, because I'm looking at differential impact and effect. So I do think that that really brings in a very, very interesting question. I don't know if anyone has a comment on that before we move to critical care and inflammation.
I can say a little bit about pain if that's helpful.
Yeah, totally.
Jeremy Orr in my group has a K23 grant from the NIH in my lab, and he just got a really good score on a RO1 as well. He's interested in the idea that we know that pain can worsen sleep. Obviously, you're in pain, you don't sleep well. He's interested in the other way around, that disrupted sleep contribute to physical pain. And so he has a paper in Pain, which I'll put in the chat, that's in press, where sleep apnea and other forms of sleep disturbance are strongly associated with pain. And he has some data from the Sleep Heart Health study as well, which he's about to submit for peer review, that suggests as well in large cohorts that physical pain and sleep apnea are linked, or other forms of sleep disturbance. The reason that's interesting is potentially, physical pain could worsen sleep. So poor sleep could worsen physical pain. We've sort of speculated about a vicious cycle, or maybe some opioid use disorder, if you could break the cycle by improving sleep, that perhaps the opioid requirements would go down. And actually, orexin antagonists look like a good therapeutic strategy there. The preclinical data look pretty compelling.
Yeah. Prior to COVID, we had put in a UO1 grant looking at a similar concept, because one of the biggest causes, and this has improved over time, of opiate use disorder actually were elective surgeries. And so in some studies demonstrating as high as 13% being at risk for development of opiate use disorder. And so we had put together a study with someone who's very, very expert in neuroinflammatory, Amit Baror, down at Penn, and he has this great panel of different inflammatory markers to be able to look at. And that essentially was our hypothesis, was that those who have a pre-existing sleep disorder, and we were specifically looking at insomnia, would be at a higher inflammatory profile. And then that would also constitute a higher likelihood of their being a development or risk for development of opiate use disorder, as well as persistent or worsening sleep issues and likely higher pain experience. And that vicious cycle is one that makes a whole lot of sense, because when you're looking at it, the most simplified version of sleep-wake control of process C and process S, the factors that we sometimes will say account for process S or homeostatic drive generally is adenosine. But the other factors that have been very clearly attributed include things like IL-1, IL-6, tumor necrosis factor, alpha, nitric oxide, et cetera, which is the same things as to why we see in critical care that there's going to be these differences. Gert, go ahead.
Yeah, no, I'm sorry, I don't have anything to add to this relevant questions, but if it's okay for you, I wanted to come back to something you mentioned
Sure.
earlier as well, about the MSOT and cannabis, and maybe now I want to add about the opiates and MSOT results. I know in every textbook is written that if someone has been using cannabis or opioids, MSOT is not reliable. But in fact, I'm not aware of any data supporting this. I think it's an opinion. So I'm very interested in your opinion, or maybe you do
Yeah.
have data. I think also if you talk to physicians who are really working with people who are addicted to opioids, they tell you they are not sleepy. And maybe that's related to the increase in hypercretin cells that we found, and also were found in mice. But I think this is very intriguing. I
Yes.
think that several persons who may be addicted may be prevent from having a diagnosis because of this, let's say, my opinion, beliefs. Right?
Yes. Yes. No, I think that it makes all the sense in the world. I think that many times we apply what we know in regards to typical physiology, and then say that then means that in pathology that it's going to look this way or that. But I agree with you that I do think that having data to support whether or not the intoxication or the withdrawal or which especially with cannabis as well as with opiates, would be very, very helpful to better understand. And this is where I also think that we're a bit amiss in sleep medicine sometimes of using a singular measure to be able to describe anything. Very frequently, I describe to people, even if I want to talk about narcolepsy type 1 due to CSF orexin deficiency, it's not the orexin deficiency that is causing the symptoms. It is the orexin deficiency's impact on a system that is causing the symptoms. And
Yes.
therefore, that is going to be a major driver. And we need to be mindful of that, especially when we think about the repletion of orexin, of what now will that new homeostasis look like? So that dysfunctional homeostasis is still someone's homeostasis. And so I think that we very frequently are thinking very binary or singularly, and it's never singular. If you look at any other disease state, it's always the failure of an interaction that results in a disorder. And many times the adverse events we see can be anticipated when you're trying to recover that pathway. Atul, did you have something else you wanted to add?
I should have shown some respect for Janet Mullington, who did some of the early work in this area, a good friend of mine in Boston, where she would sleep deprive people and measure their pain thresholds. And as you get more sleep deprived, you get more sensitive to pain, which fits with that vicious cycle. So I wrote a
Yeah.
thing 20 years ago, I think in 2007 or something, in Chest about the speculation about the vicious cycle. And it's taken us 20 years to get there, but there may be some truth to it. The other
Yeah.
point I wanted to make, which is following up on Geert's point, is sometimes in our physiological studies in sleep disturbance, we'll see the arousal threshold actually get lower, meaning it's easier to wake up with opioids, which is the opposite of what I thought was going to happen, where the arousal threshold should go up. And we speculate that there's a lot of histamine release you get with opioids sometimes, which is why it can cause hypotension and whatnot. That histamine might be alerting in some cases. And when you see
Yeah.
these patients clinically, they're not as sleepy as you might expect for the degree of sleep disturbance and whatnot. So I think there may be some truth to this alerting thing, which was not what I anticipated until I started studying them.
Yeah, and it may not be a direct impact on the histamine. It may actually be more on the orexin triggering the histamine, because there was a beautiful paper I published last year in animal models, again, that were looking at the selective agonism versus antagonism of orexin, and there being kind of this pain to itchiness phenomena. And again, thinking back around this kind of system and whether or not that contributes to some of the profiles that we see in individuals. Now, I think this is a good intro into us talking about orexin, critical care, and inflammation, because we already started really that conversation, talking about the different ways that pain may be contributing. They're obviously, beyond there being the inflammatory piece, there also is the mental health piece that Craig had touched on also in a variety of different areas. But when looking at that inflammatory piece and the critical care component of it, I'd first go to you, Atul, in regards to what thoughts do you have there? You've alluded to some of the work that you or your colleagues have done in regards to the DORAs, or the dual orexin receptor antagonists, and just wondering if you have other thoughts, because for me, when I talk to any critical care specialist, the main thing they worry about is like critical care delirium, and many critical care units now will have kind of circadian protocols, or what they call sleep protocols, where they're really trying to normalize sleep-wake cycles, which again, orexin has a very, very significant role in. What are your thoughts there?
Yeah, it's a complex area. So I do a lot of research in sepsis and respiratory failure. I do a lot in sleep disorders, and usually they don't overlap that much, but I started blurring the lines there a little bit. So there's some good animal models, mainly out of Japan and China, I think, where in LPS models of sepsis, you see suppression of orexin levels. And if you give back the orexin, in fact, there's a mortality advantage in these animal models. It suggests that there may be a therapeutic target there. Interestingly, from what I understand, at least, the suppression of orexin is not just a function of severity of illness. It's not just that sicker animals are sicker, but there's actually some mechanistic basis for that. And again, there may be a therapeutic target there. With regards to sleep in the ICU, yeah, sleep disturbance is now becoming a therapeutic target. So Wes Eli and others have been talking about that for a while. And John Hoganish, who some of you know, has done some good work on sort of chronotherapy and timing of things in the hospital. And we ignore sleep, we ignore light, we ignore all these things, which are obviously important in terms of things. With regards to sleep apnea, there are three or four things. In fact, one is a brand new story. So the ApoE epsilon 4 gene that we know is important in Alzheimer's is also important in delirium. And Dan Gottlieb has a paper saying it's important in sleep apnea as well. So there may be some common genetic links there. Number two is, yeah, disrupted sleep can certainly contribute to delirium, and there may be some long-term neurocognitive impact of that as well. So Jamie Labazada in my lab has a NIH grant to study that now, and she's studying the frequency of neurologic checks. If you check too frequently, it disturbs sleep and create delirium. If you check infrequently, then you miss sort of catastrophic complications. So she's randomizing to see what's the right duration. The brand new thing came out. David Gozell was a co-author. I hadn't seen this before, but
What
hypertensive.
is David co-author on? That's the bigger question. What isn't David a co-author on?
He had a paper recently on hypertensive crises, and that was where blood pressure goes crazy. And actually, OSA was an underlying risk factor, at least in some cases that were out of Spain. The other thing we're studying now is Alan Cifuentes is a junior person in my lab who's studying sort of sleep disturbance during recovery from critical illness, where maybe disrupted sleep is contributing to long-term neurocognitive sequelae. So, the data suggests that short-term neurocognitive performance predicts long-term neurocognitive performance, and maybe disrupted sleep is on the causal pathway there. And so she's going to study that now. So it's an interesting area, although we certainly need a lot more work in that space.
Yeah, and I think that some of the things that I've heard you saying is that we may need some either panels or of either biomarkers or multiomics or others to better understand where we're at and make real-time decision making. We see this in open heart surgery. They're constantly getting their panels of labs to be able to say, is there something that we need to do immediately? Because even though the pump looks like it's doing what it should, the blood is telling us something different. In regards to the post-op delirium or the ICU delirium, one of my colleagues has a company that they had done some work with Institute in Boston as well, and they had demonstrated that p-tau 217 and 181 were markers of post-surgical delirium, which for me, when they had presented me this data, I said, you don't have markers of post-surgical delirium, you have markers of someone who's developing Alzheimer's. And so if there's opportunity for there to be earlier intervention or recognition, again, even if it's a part of a critical care pathway, it can have a greater holistic impact longitudinally. I think that really is giving us less questions or doubt in the moment and allowing for us to potentially create some new novel interactions. Now, with thinking about the neurodegenerative and all of these other pieces, I would be amiss to not also acknowledge the fact that we do recognize that there is a circadian permeability of the blood-brain barrier, thanks to the beautiful work that Amita Segal from UPenn has done, even demonstrating again for that there is a circadian expression of multi-drug transporters, so playing to the concept that you had given around chronotherapy, as well as thinking about the lymphatic system and the enhancement of slow-wave sleep. There's been some data to give a suggestion in animal models that you can use things like oxybate, sodium oxybate, to be able to enhance lymphatic system because it will enhance the amount of slow wave sleep. So really thinking about some of these novel concepts, is it a combination of an oxybate with an orexin, whether it's an agonist or antagonist, depending on what it is that you're trying to get at. Atul.
Yeah, just two other comments along those lines. Well, I think you maybe already made the point, but what I was going to say, I was a resident a long time ago, more than 30 years ago, and I remember an old school clinician at the Mayo Clinic where I trained used to say septic encephalopathy, which is what we used to call delirium. He said to some extent it's permanent, and he just sort of said that based on clinical experience. But it turns out that might be right. That sleep disturbance acutely might predict that long-term thing. And again, Wes Eli has some data to support that as well.
Yeah.
Yeah.
Yeah, no, I think so. And again, when I look at IL-6 especially, there's some very interesting data to give a suggestion that IL-6 may also contribute to some increased permeability of blood-brain barrier, which makes me also wonder around the whole brain fog experience and hypersomnolence disorders, and how that might relate. And to your point, the orexin 1 pathway actually can have some influence on that IL-6. So I do think that there's a lot of very interesting things here. What I don't have on this which I think is even probably the most fascinating, is the role of orexin in cancer. The cancer development, the cancer hypersomnolence or fatigue, cancer risk stratification, and there even being differences across organ systems, potentially GI cancers being much more susceptible to some orexin-related implications.
Yeah, just sorry to interrupt, but just to follow up on what you just said, with the orexin stuff and sepsis, there's some data, as you point out, that the orexins may be anti-inflammatory, which could be beneficial. There's
Yeah.
some release of corticosterone, which might be beneficial, though you could argue that either way, and then some release of catecholamines, which might help cardiovascular function. But again, a lot of these patients are maximally catechol stimulated, so again, you could argue that either way. But yeah, there are mechanistic studies which are quite intriguing.
Yeah. And I think to relate that to a person living with narcolepsy, it's not uncommon that we see dysautonomia. And so you can see dysautonomia both with an overexaggeration of catecholamines and one without that appropriate catecholamine. And so you can see a very wide range. What I also would say is that very frequently we think of more of the prototype of postural orthostatic tachycardia syndrome. However, I would say that I also see individuals who they fit the clinical picture of a gastroparesis, as well as temperature instability, piloerector symptoms, et cetera. But sometimes when they get tested, they don't fulfill the criteria, which raises the question also of, are they the right criteria for a person who's existing in dysfunction? Because it takes a lot less to put them over the edge. Craig, one of the things that I would ask you is, I anticipate that you may see some people after a significant trauma with critical care illness or living with chronic disease. And I would anticipate again that there may be an orexin role there. Is there any characterization that you would give for someone who would be kind of that clinical picture? Maybe they have an anxiety around their illness, or they have a true PTSD related to that. Would you say that, kind of similar to what you've seen in depression, that there can be an insomnia phenotype as well as a hypersomnolence? And then if that is true, similar to depression, where it's much more common to see the insomnia characterization than the hypersomnolence, do you see that as well?
In terms of in relation to a physical trauma with potential PTSD or anxiety?
So if they had, I would think more so of someone who's had like chronic illness, had a significant ICU stay, or if it's physical trauma. And this is purely not me asking like, did you do a peer review literature search? It more is, do you tend to find that there's more of one characterization versus another?
So I would say clinically, I would tend to see more of an insomnia phenotype in that situation. That as you were asking the question, I started thinking of several patients who I've seen who will have anxiety about a medical illness, and that often it's pulmonary in nature, and so they'll have trouble breathing or shortness of breath. And that goes along with they have panic attacks. Well, is it the pulmonary pathology or is it the panic attack? Well, it's often can be a little from column A, a little from column B. And those individuals, in my experience, tend to have this obsessive rumination that is more consistent with a insomnia phenotype in what I've seen clinically.
Awesome. All right, so now the question is dual or selective? So in the world of insomnia, we've mainly seen dual orexin antagonists outside of the most recent being studied for depression and insomnia. In the world of hypersomnolence, we now have mainly seen selective orexin agonists, specifically selective orexin 2 agonists. I do know at Sleep last year there was at least one poster presentation describing a dual orexin receptor agonist. What are your guys' thoughts? Do you think that there is a place for dual orexin receptor agonists? Do they come as a single medication, or is it a combination of medications? What are your thoughts around this?
Yeah, I think there are arguments in favor. I think one major argument is that in human narcolepsy, there is no hypercretin left. As far as you know, you rightly mentioned we cannot measure orexin B, but we know it's derived from the same precursor. So there also must be no orexin B. So if you really want to have a more causal therapy, you would expect you need an agonist that is has both affinity for the receptor 1 and receptor 2. And another, let's say, topic that can maybe add to it, I think we are very happy with the first results that are shown with the agonist. But what we didn't mention yet is the relation between orexin and metabolism. But we have the impression from these trials that although, let's say, many aspects of the disorder narcolepsy improve, there is no improvement of, let's say, the tendency to become obese or overweight.
Yeah.
So it might be, I think there might be two explanations. The explanation might be that's not receptor 2. It might also be, if the theory is true, that we lose our cells, then it might be that we lose more than just orexin, and that may explain why people get overweight and obese. But yeah, I think both could be options, and I think it would make sense to try at least to invest in a dual agonist, right?
Yeah. I would say that my personal opinion is part of the reason I show the pathways and the fact that orexin A can agonize both and B can, is that do we create a new imbalance by only solely agonizing one receptor pathway, and does that increase any other new risk? Or is there, again, for me, my thought process also is, let's say the endocannabinoid system and the orexin system do cross-agonize, and perhaps it's 2AG who has been modifying while there has been no orexin or insufficient orexin to be able to do something. Is that sufficient to now be able to go on that orexin 1 pathway? So I agree with you. I think time is going to tell, but I would say my instinct is that needing a dual mechanism, whether it's in a singular drug or a combination of medications, so that you can kind of tailor it to what the person's needs are, I think may be necessary. Craig or Atul, what are your thoughts?
I don't have a lot to add. I guess I need to be convinced that the dual is better than the selective, but I don't know a lot about that. The one thing I'll say though about the body weight regulation thing is I was a little surprised actually with orexin agonist, body weight doesn't seem to change very much. I was predicting some weight loss if there was some truth to the orexin and anorexin and these things that has something to do with appetite. So
Yeah.
and maybe the body weight obviously is complex, but maybe body weight loss from orexin agonist hasn't panned out.
Yeah, and I would say that's similar to what Gert was describing. I'll say in my clinical practice, one of the things that I very commonly do employ are going to be GLP-1s. I partner with our Metabolic Institute because I feel as though they're more equipped with being able to follow the person through the full pathway. But also, if I'm referring for weight management, I don't want to limit them to just my comfort of prescribing a GLP-1 or a GLP-1 GIP. Really to make sure that they're getting the full complement of services, especially if they end up needing bariatric surgery or otherwise. But I agree. I think that may be a part of the orexin 1 maybe is contributing, or there's some other downstream that would be beneficial. Craig, what are your thoughts?
Yeah, well, I think in terms of whether or not we'd see benefit with the dual, I'm on tool side is that, like convince me first. I mean, one thing we did not see in data for the orexin 2 selective agonist for weight loss, but they were 12-week studies. So it could be that it take longer for us to see an effect possibly. We don't know. And we're just now able to get, has it been 13 years since the FDA approval of suvorexin? We're still not having a selective orexin receptor antagonist that is approved on the market. We're hopefully close to one. But in terms of medicinal chemistry, it's very difficult to get that selectivity. So we're just starting to figure out how to get these really good druggable targets for each antagonist. And agonism went the other way. They went specifically hard at the orexin 2, and we can see, but I like the idea of personalization, of being able to customize it, because we're not sure yet of what we'd see in large scale studies of a dual agonist or of a orexin 1 selective agonist either.
Yeah, and I think that that's an important part of kind of the education that may be necessary in the clinical environment. Why for insomnia was a dual necessary if orexin 2 pathway is the only thing that is wake promoting?
Mm-hmm.
Right? Where similarly, we know that the orexin 1 pathway also has some influence on the non-REM sleep signatures. And so I do think that this is a very important part of the conversation, is really understanding the why. So why in one type of sleep disorder where I have too much wakefulness, I can't sleep, I need dual, and then another where I want that much wakefulness,
Yeah.
I only need a selective. And I think that this also plays into, and the reason why for my brain, I think about the opportunity with a dual, whether again it's I have it all in one drug or it's combining, is thinking about, if you see one person living with narcolepsy, you've seen one person living with narcolepsy, because each individual has such different journeys. And to the point that was made earlier, if I'm a person who developed symptoms at 5 and didn't get diagnosed until 15 or 20, looks very different from the person who developed symptoms at 15 or 20 and got diagnosed in that same year, which is very few and far in between. And so how the development or the accumulation of multimorbidity over time, and do the combination therapies, do they actually help us to be able to treat? And I think also, I think about that, perhaps I'm a little bit conditioned to my approach currently, is that polypharmacy tends to be the rule for patients living with narcolepsy, where monotherapy would be the exception. And so I wonder if it's not a dual, is it a selective plus? And so I'll also pose that question. If it's a selective orexin agonist, because that's likely what we'll see come to market first, do you believe that that will be it, or do you think it's that plus something else?
Yes, again, a very relevant and good question, but I think what we should keep in mind as well, that there are indications that these people using the agonists are improving to extreme level during the day, but there are indications that nocturnal sleep is not that much improved. So I think it's not just about receptor 1 and 2, but we also don't know exactly about the kinetics. Is there still a problem at night because there's still hypocretin left, or is maybe that there's not enough or orexin left during the night? I think these are very important aspects to be solved as well. Huh?
Yes. Yes, I agree with you. I also think that for me, it's also trying to understand, what does the responder profile look like over time, not only for narcolepsy type 1, but also for type 2 and potentially for IH as well. What I think we've seen in both of the further along clinical trials is that there also seems to be this neurocognitive benefit that comes at even a lower dose and even potentially at an earlier time frame. And so really brings into the question of does this create a broader application of who this should be used for? And so there's some question as to whether or not the first orexin agonist may only have an indication for narcolepsy type 1. I would say I would have absolutely zero doubts that in combination therapy, that it would prove to be quite beneficial for those who have orexin, who have narcolepsy type 2, as well as those who truly have narcolepsy type 1 but don't have CSF deficiency. And potentially it might be measuring a different outcome, such as the neurocognitive or the brain fog type of symptoms. Atul, did you have something you wanted to add?
Just to follow up on Garrett's point, the data I saw on overcorrection were quite compelling. They obviously met their primary outcome. I think they had like 14 different secondary outcomes, all pre-specified, all controlled for multiple comparisons, and everything was getting better. So the sleepiness got better based on the MWT, the cataplexy got better, nocturnal sleep got better, although admittedly not much. So we'll have to see more data and more experience, but it wouldn't surprise me that adjunctive therapy for sleep fragmentation, for example, would be helpful, at least in a subset. The other point I'll make, when I first saw the data in terms of the Epworth improvement, it's like, oh my God, there was like literally my jaw dropped when I saw the New England Journal paper from a couple of years ago, although that, just the improvement was amazing. I would have thought these patients would feel like they're wired on cocaine or something when you see that much of a improvement, but you talk to the patients and they just feel like their disease is gone. It's sort of
Yeah.
replacing a physiological deficiency kind of thing rather than being like, on high dose stimulants or something. So it's quite striking, but I think we'll need more clinical experience to see who needs adjunctive therapy.
I agree with you. Now, the final question is, what do you predict or hope to see for the future of orexin-related medications and research? We've only, although, can you believe it or not, we have literally 11 minutes left. We somehow managed to fill about an hour and a half of time talking about orexin and staying on one singular slide. I told you guys that you wouldn't have a lot of homework to prepare for this, and you guys hit it out of the park. But this still is only scratching the surface. We really could have done this entire landscape and talked about sexual dysfunction, about neurocognitive, more about neuropsychiatric. This was only just, again, it's starting to bridge that gap. Cancer we have alluded to, but there's so much more that I think could be dug into. I would ask each of you to give some predictions or hopes for what you would want to see for a future orexin-related either medications or for research or a combination. Gary, I'll let you kick it off.
Okay, I will. Well, I'm really looking forward to have them on the market, because what you see in the trials is really remarkable. But I think what we discussed, I'm not sure if it will be just the receptor 2 agonist that we need. We don't know exactly, is it what I already mentioned, kinetics or not, that explains why nocturnal sleep is not in all patients really improving, or might it even be better also if we take into account the weight problems, that we combine it, for example, with sodium oxybate, of which we know that many people can be supported in losing weight when using it. So I have, let's say, reflections in that direction. And well, you already mentioned them almost all.
Yeah, and I think that we also have covered a lot of different future research suggestions for the future. Atul, what are your thoughts?
Yeah, I don't have a lot to add to what Gert said, but I'll say 2 or 3 things if I may. One is, as a physiologist, I love the idea of replacing something that's deficient because it just makes sense. But I also believe that pharmacological dosing of this may be helpful in patients who aren't deficient. So in type 2 narcolepsy or in idiopathic hypersomnia or in obstructive sleep apnea with residual sleepiness, it'd be worth doing randomized trials in that context, number one. Number two is, as I mentioned before, there's some data that obstructive sleep apnea and upper airway motor tone may be positively influenced by orexin agonists. So I'd like to see careful physiological studies on upper airway motor control, which is a little bit self-serving for me to say, but would be of interest to me, certainly. And the third would be sort of long-term follow-up. So we have a few recent papers with Chris Kaufman and Rakesh Bhattacharjee, who you know well, Anne Marie, just looking at narcolepsy and cardiovascular risk from the disease itself, not from the stimulants. And there is some risk there. So I'd like to see long-term follow-up on some of these pharmacological agents to see if they improve long-term outcomes in narcolepsy. That'd be of interest to me.
Yes, I think that makes a whole lot of sense for us to look at that. And again, I think this is where I would really want to make sure that we're understanding both the orexin 1 and orexin 2. One part, again, that we didn't even get into is thinking about variations in terms of genetics, calcium channels. Is there complementary therapy there? Should we be prescribing something like, I don't know, topiramate in regards to trying to enhance some of those? Craig, what are your thoughts?
Well, first was one kind of brief observation on the dual versus selective. I was thinking about that. I remember when semaglutide 2.4 milligrams first came out, I had a jaw-dropping moment with that. Wow, look at that weight loss. I've been prescribing GLP-1 agonists in my practice for almost 10 years. And I thought, wow, how could it get better than this? And then tirzepatide came out with the GLP-1 and GIP receptor agonism and even increased our expectations there. So maybe that could be something with a dual orexin 2, orexin 1 agonist, is that as jaw-dropping is what we've seen so far, who knows how high the ceiling is. But in terms of the future, I'm excited for more. Right now, oveporexton is being looked at for narcolepsy type 1, but narcolepsy type 2, and then also IH, as we've mentioned just very briefly, those are conditions where there are substantial morbidity and functional deficits, and I'd love to see that. Alixorexton from another company is maybe a little bit in the lead in terms of those indications. But then moving down the line to the obstructive sleep apnea and those with residual EDS. That's what I see a ton of that in my practice, given that up to 1 in 3 people with major depressive disorder could have OSA, and a large percentage of those individuals, often even with great airway therapy, have residual sleepiness. And then obviously I'd love to see, as I mentioned very early on, the orexin agonists being looked at for the pure psychiatric indications. ADHD and perhaps major depressive disorder, maybe something like anhedonia, just transdiagnostically, because we see that in schizophrenia, we see it in bipolar disorder, MDD, so on and so forth. So there's just, the sky's really the limit in terms of my imagination, but we need data to be able to tease this out. And hopefully we can help a whole lot of people with some of these medications if they continue to be pursued in some novel and bold indications.
So someone had just put a question in the chat, or in the Q&A rather, that I think also poses a great area of future research. Why do you think people with normal orexin systems need higher doses of orexin agonists than people with deficient orexin? Or why are people with deficient orexin more sensitive? Again, what I would state is that if I have nothing of something and I give you a little bit, I'm going to have a very robust response. It basically is almost like the anorexia for orexin. And versus I'm a person who maybe is gluttonous of orexin and I have a desensitization, I'm going to need more to be able to overcome and be able to really sensitize that receptor. So I really think it is a story of the haves and have-nots. However, there probably are also some variations within that, because we probably do have some other mechanistic contributions, such as whether there's a calcium channelopathy. So even though I have the right orexin and I have the right receptor, I'm not signaling appropriately, or I have inconsistent signaling. So I may need to over signal or over connect in order to confidently transduce that downstream signal. But again, this is my anecdotal kind of looking at the literature and trying to make sense of it. I think for me, I would just echo what everyone has stated. There is so much opportunity here. And part of the reason that I was very insistent to Christine to say we are not just going to talk about sleep-wake was because the fact of how much would we have missed out on by not having this conversation? How much opportunity have we described in regards to the way the orexin system may transform all of healthcare? This really is a moment in time that I am hoping that we see that with the era of orexin agonists, that we actually start to see sleep medicine being integrated across the healthcare system. And if it's through the ability to recognize a rare disorder like narcolepsy, to be able to actually reach the majority and even unveil those who are undiagnosed, I look at this as a tremendous opportunity and a privilege to be a part of. Future areas that I think I would love to see, I can't emphasize enough, cancer, 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 cancer. With the World Health Organization stating that up to 50% of cancers are preventable disorders, and recognizing the growing number of sleep and circadian disorders that we're seeing nationally and internationally, and the younger age of onset of cancers occurring, I really look at it as, is there an opportunity there? Is there an opportunity where these will be utilized, number one, as a direct treatment for cancer? Orexin A has been shown to be very beneficial in things like glioblastoma multiforme, orexin 1 agonist shown to be pro-apoptotic in cancers in the GI system. And so being able to look at this again from a different lens, I think would be tremendous. I think the earliest area that we're going to see research that is going to be very impactful to the whole person living with narcolepsy, would be the real world evidence generation after these drugs become available and people are utilizing them clinically. Understanding what is the responder profile like, what are some of the other modifiers? Do we start to see that there is a gender difference that does become unveiled, either through there being catamenial differences or age-specific related differences? And then the final piece would be, let's learn something more about how we can measure what is central versus peripheral, and then how does this impact the overall individual? Recognizing that there may be more for us to continue to learn about this story. With that, I would say to you, thank you guys so much. This, honestly, I had a lot of fun today. I hope all of you had a lot of fun. I know everyone was very nervous because the way that I generally run these is that no one gets to see anything that we're going to talk about until the day of or the day before. So for everyone who attended today, please know that no one knew what I was going to ask until literally about 10 minutes before our presentation. And I think that they did amazing. And the reason they did so amazing is because you have extraordinarily brilliant minds who are able and interested in collaborating and really evolving what sleep medicine and really transdisciplinary medicine can look like. So with that, thank you, everyone. And again, thank you to the corporate partners for supporting this program. Without you, the ability for us to think about what the future of research and what the future of this landscape will look like wouldn't be possible. Thank you, guys.
Thanks very much, Anne-Marie. Thanks, Christine.
Thanks for having us.
Yeah, thank you.
Bye, Craig.
But you said webinars until all clear. I just stare at the camera and smile.
Oh my God, no, wait too. Okay.
Thank you.
Bye.
Bye.